Welcome to Recovery with Root, a podcast centered on topics surrounding mental health and addiction. Through our Advanced Recovery Institute, a new entity of the Root Center for Advanced Recovery, we are committed to research and training to elevate clinical care. We hope you find this podcast informative, and most of all, we hope that it helps improve the lives of others. Remember, we're in this together, and recovery is possible. Welcome back to another episode of Recovery with Root. I'm Margot Farrell, Chief of Staff here at the Root Center for Advanced Recovery. Excited to bring you another episode. We'll be joined with Dr. Yifrah Kaminer, who you may remember, he was on our podcast season 1. He is the first ever grant recipient from Root, the first fully funded Root grant, and he's here to talk to us about his study. Thank you so much for joining us again.
Thank you, and let's make sure that people know that I'm with the University of Connecticut Health and faculty with the University of Connecticut School of Medicine.
Yes, absolutely. So you were the recipient of our first ever fully Root funded grant, and it went to you and your team at UConn. So why don't you talk, just to give folks, if they maybe missed out on the first episode, tell them a little bit about what the study was, what you were looking at, and then we'll get into some of the findings that you've had here now.
Sure. One of the most prominent and tragic public health problems in the United States is opioid use disorders that lead to drug overdose that in many cases is fatal. Just to give you an idea about the magnitude, so the last statistic we have from 2022, 2023, more than 110,000 Americans perished due to the use of drugs, which is an unbelievable number. And somehow we were a little bit overwhelmed by COVID. So we have not done what we were supposed to do in order to address the issue. Nevertheless, because I'm a child and adolescent psychiatrist by training, with special interest in high-risk behaviors and addictive behaviors, I became interested in the phenomenon around 2016 because I kind of probably thought, or brainstorming with myself, that this population of people who are using drugs and definitely, unfortunately, ending up with fatal dosage is not, if you will, it is heterogenic. So there might be some subgroups within it that we should identify in order to interact with each one of these subgroups, because the same way that we talk about the depressions, the schizophrenias, the epilepsies, it's not only one entity, it's not homogeneous. So we need to break it down to subgroups and address subgroups that we think that are amenable to what we think might work with them. So my focus has been on people, young people up to age 25, what I would call youth. Why 25? Because allegedly this is the age that the brain completes its construction. The brain develops actually, interestingly enough, from the back to the front. Instead of other things in life, they start from the front to the back. And particularly an area that's called the prefrontal cortex that is responsible for, if you will, cognitive decisions, inhibitions, and trying to defer unhealthy behaviors that are pretty much impulsive and sensation-seeking oriented, such as substance use. So we started, first of all, to look at data of the Connecticut Medical Examiner at the University of Connecticut campus, because my theory was that a certain percentage of these young people who perished probably were suicidal. It wasn't just an accident. And lo and behold, we found, we reviewed death certificate from 2016, 2018. And again, I want to thank Rebecca Burke, who's been working with me on this project. And we find that a little bit more than 10%, the medical examiner decided categorically that there were suicides. You may say it's only 10%, but any number is meaningful, and the fact that people might be using it as a form of suicide when there are all kind of other means. But as we know, with suicide, which is one of the topics I'm very interested in, has to do with availability of means to cause harm to yourself, whether it's guns, ropes, medications, and drugs. Then we've done another study, and 2018, 2020. Also, both were funded by the University of Connecticut. And we looked at the same results, and we saw actually an increase not only in the percentage of suicidal behavior that ended up as complete suicide, but we also saw younger kids. And actually, Connecticut has been report of several kids, even in middle school, that basically died due to fatal drug overdose. There were actually in the media these reports, and they were probably accidental, but it's a reason for concern if the age is dropping down, meaning that these drugs are available to younger and younger kids, and the drugs become more and more fatal in terms of the potency, like fentanyl, which is a synthetic opioids, is roughly speaking 50 times more lethal than heroin. So even teeny tiny bit of it can end up in a tragedy. Not to mention, by the way, that we find out that even though a lot of people now are very aware of it, and there's naloxone, which is a medical drug that's used to counter the effects of the mainly opioids on the breathing system in the brain, that even those who've been resuscitated and saved, many of them have mild to moderate cognitive damage, which is something people haven't thought about because it's something similar to having a myocardial infarction, that if the heart does not get enough blood and enough oxygen, then the tissue cannot function and becomes necrotic and dies. Something very similar might be happening in the breathing system in the brain, that because of the effect of the fentanyl, for example, until the person is being resuscitated and hopefully saved, still damage is being done. So after we got all this information, I wanted to start to work and examine people who have attempted, if you will, or OD'd, and that are survivors and are in treatment. And that's how I came to the Root Foundation in order to have access to your clinics. And I'm, you know, I'm happy that that foundation decided to provide us with this support. And we basically interviewed clients with opioid use disorder in methadone maintenance clinics of the Root Foundation in Connecticut, 3 or 4 of them at clinics in central Connecticut. And the questionnaires had to do with finding out their level of depression, attempted suicide by or not by necessarily drugs, and history of overdose, and try to look at all this information that perhaps would provide us with some cues how to address these issues in the future, because one of the most alarming findings was that several of those young people up to age 26 have gone through several overdose events, which increases the likelihood that it's going to happen again, and maybe next time it's going to end up as a mortality, not just as a morbidity.
Wow. What do you think is the most shocking thing that came from all of the results that you've gathered throughout the study? Was there anything that you didn't expect?
Well, it's actually the first study of its kind, definitely in this relatively young population that I'm interested in. I was not surprised by the high level of depression, but I was surprised by the constant occupation with death and suicidality, which is expected because we know a population of people who suffer from substance use disorders have high probability of co-occurring psychiatric issues, from PTSD to depression and so forth. And also both mental health issues and substance use issues are associated with suicidal and self-injurious behavior. But the percentage was very high, and I didn't expect to see several people so young with multiple overdose events. And that brings, of course, other questions that I didn't ask in this study. A couple of people conducted similar studies with adults, like asking people specifically, was it an intentional attempt? Was it just an accident? And it's a little complex to get into it because people have memory losses. People sometimes rely on what somebody else told them. Many people who've been resuscitated um, escape from emergency rooms. They don't want treatment, which is another issue because if we can't identify them and work with them, then it's a liability. It's just a matter of time when it will happen again. An interesting finding actually was that we focus a lot now about the gender, ethnicity, race, whatever. We didn't find any difference in terms of sex, gender, but um, clients who identify themselves as Hispanic had lower level of suicidality. I cannot um, stipulate about causality because, for example, we didn't measure religiosity. Religiosity is a very powerful aspect in terms of suicide. People who are very religious tend to be less, you know, uh, let's say the probability of suicide is less than others who don't. There's all kind of issues. So I'm just bringing it as something anecdotal. I don't know what it means, but this is what we found because we wanted to see if we can break it down into ethnic race issues. Next time, if I'll do it, I'm going to also check things about environment such as religiosity, family history. I mean, it was a relatively not a large scale study. It's a 1 year study, so we try to focus on the main issues, but hopefully, maybe we'll do some more things in the future.
So what about the breakdown with age? Because that was really your focus, was to look at adolescents and young adults. What do you think is the most important takeaway from what you gathered with that age group? Because it is just hearing it at face value, it's startling to think that we're
Right.
talking about,
Right.
kids.
All right. Well, so I'll break it into two things. In terms of the specific study of the Root Foundation, we focused on people who actually identified as clients, as patients who take methadone because they have opioid use disorder, and the range was 16 to 26, but we didn't see anybody under 18. It was 18 to 26. And we know that the population that's using drugs, uh, actually the age group between 18 to 35 is overrepresented compared to other age groups. However, I think that perhaps the listeners, the watchers, might be interesting to know what's happening before people become opioid use disordered in terms of diagnosis on methadone. So the take-home message that we know also from prevention issues is that there are like two kind of casualties. One kind, people would say, well, it's expected if you're using drugs and you suffer even from a disorder that was diagnosed, um, it is more likely that bad things would happen. But we know all these young people who kind of experiment with drugs and try this and try that. And we see casualties. We see kids who unfortunately perished because they thought they were using, let's say, Ritalin, which they were not supposed to use anyway because they don't have ADHD. It has been diverted from somebody else. And it was laced with fentanyl, which is deadly. And there are also more drugs coming down the pipe. I won't get into title and names, but it's like an industry. You always come with something new, and we play cops and robbers. But there are some new products out there. There's one called xylazine, which is an anesthetics for large animals in veterinarian medicine. We haven't seen any before 2019, and then it skyrocketed. So people using xylazine and fentanyl or heroin, it increases the likelihood of permanent damage and death. So the bottom line is to young kids, don't use drugs, and at least for the simple reasons that what you think that you're using is not what it's supposed to be, and it
Mm-hmm.
can be lethal. I mean, all this experimental use, or people who take, for example, Ritalin um, to study before exams because they want to have a stimulant to stay awake, and they perish out of the blue. So this is a major message in terms of prevention for high schoolers and for their parents.
Were you finding that a lot of times, like in your interviews and when you were speaking with folks, that there were multiple situations where folks maybe thought they were taking one thing and lo and behold had something completely different? Like the overdose was a shock to them because they weren't fully aware of what they were taking?
I think that the population that we've been working with on this study most of the time knew what they were using because they had substance use disorder and a very clear drug seeking behavior. So there's some kind of street savvy kind of things. I think that this accidental issue, basically, again, could be a couple of ways to look at it. One is you don't know what you're doing. So this is for the novice, adolescent, young adult who doesn't know much. The other accidental, in terms of people who are non-users, is a matter of dosage. And you may take more than you think that you do. Purity level can change. Um, so um, that again can lead to it. Now, something interesting about the psychology of users. You can say there's like the passive and the more active one. The passive one, you say, well, don't you understand that using what using may cause, you know, tragic accident, you may die? So it's not a real insight. They know, but they say, this is what I'm doing. I got used to it. I want to get high, and if there's a price for it, so be it. But this is passive, meaning if something bad happens, so be it. The more worrisome is those who say, yes, and actually, I'd like to die. And so I don't care if this happens. And by the way, I have available mean, which is the fentanyl. It's the same way that you have a gun. Uh, you know, you can use it anytime when you're suicidal. That's why, in pediatrics, um, we teach people to um, parents to lower access to lethal means, the same way that you don't want kids to drink. So don't keep liquor in the house if your kids break into the liquor cabinets and have all these parties or drive under the influence. However, the correlation between those who are more passive about it and more active, based on a study by Hilary Connery from McLean Hospital in Boston, is about 40 to 60%. So there's a very high overlap between people that are more of a passive attitude
Mm-hmm.
versus an active attitude.
Hmm. And that was pretty standard across the whole study and at least the whole population that you were looking into for this specific study and studies you've done in the past, or is this really something that came out of this one?
Yeah, well, unfortunately, even though it's such a common phenomenon, there's not a lot of studies on it, and this is why we need to have more studies. Even some people don't even know if they OD'd accidentally or not. So might be again two explanations. Everything I'm saying two explanations, two options. One is that they don't want to disclose it because they don't want any ramification or action taken, like you will commit them
Mm.
to inpatient, or they really don't remember because they were dazed and confused using Led Zeppelin line,
Mm-hmm.
and they don't remember really what happened, and they have a lapse. It's almost like a blackout until they got resuscitated and then revived. So it can be either or. But there's another interesting study that I read that was very powerful and surprising to some degree. It seemed that the most powerful psychological impact on people who use drugs is not their own personal OD, but OD of a close friend or relative.
Hmm.
It was more, so to speak, it has shaken the systems and make them rethink more than what happened to themselves. Um, Kind of interesting.
Well, it makes you wonder if some of that memory aspect that you're talking about plays into it. if they witnessed somebody else have it happen to them and they watched it happen, it's obviously a lot clearer in their mind than if you're saying there's that little lapse of timing from when they come back, when they really come back to their senses, and things may not be as clear. So maybe it doesn't seem as scary to that
True.
person in the moment because they don't remember it.
There's also probably an altruistic aspect because I'm always surprised by the altruism, how people care for other people, not for themselves. I don't care what happens to me, but I don't want these people to get hurt or perish. It's almost like when people come and give talks to young, um, like people who are in AA, and we invite them and motivational speakers to talk with young patients, adolescents,
Mhm.
and they say, "Don't look at me, and but don't be like me. Don't do what I did. So
Mhm.
this is my legacy. I'm trying to help other people, and a lot of people in recovery. It's very important for them to network, and particularly with young people, say, don't get to where I am now.
Mhm.
Um, don't do it. So that's kind of the things that maybe it's the altruism, it's the compassion, it's the elicited kindness from people who are really down, down and out. So
Mhm.
at least I want to help other people.
No, we talk about that a lot. I mean, we've also been hiring recovery coaches onto our staff, and we
Yeah,
know that there's, a lot to be said for learning from someone else with a lived experience and sharing those lived experiences with each other. So we have folks who even come to, some of our groups and talk to our patients as well. So that definitely speaks with what you're seeing. Was there anything in the study that you thought would be instrumental in how we could go about changing care or changing information that we disseminate to people? Like, what's the biggest takeaway that you think is something we can actually apply to help make a difference going forward?
well, there's several issues. Um, First of all, there's something about policy, and I put it out there for discussion because a lot of talk, but not enough action. Um, the issue is how active do we want to be in terms of preventing additional overdose? So, and again, there's a discussion and the conflict here between personal autonomy to do what they want, especially when they're not minors anymore, they're adults. It's my life, I do what I want. And if it's caused damage to me, it's on me. If it's caused damage to other people, I got it. You need to intervene. Um, Versus the fact that I say, look, in the same way as you come to emergency room and we find that you're suicidal and your suicidality is quite ominous and active, I may have to commit you legally to treatment, and then let's see how it goes. And one of the reasons I do it because you are not right now in a state of mind that you are able to make logical, sensible decisions about your safety and other people's safety as well. And hopefully, being available or making treatment available to you and processing um, everything that have to do with your mental health and substance use issues might be helpful in the future because we know, for example, people who are in methadone maintenance have a much higher likelihood to stay alive as compared to people who are not coming to methadone maintenance. And that's why methadone maintenance and buprenorphine and so forth need to be available to those who are willing to do it. And we don't have enough of those, which is another problem. So this is one issue that I think it's worthwhile discussing and even studying, by the way. Um, a second issue is a lot of time people think about insight. They saw the light, like, ta-da, it's some kind of a spiritual enlightenment, like Big Bill,
Mhm.
the person who started AA. Insight is only a first step. Insight means increased awareness. Good, we need to start. But then we do what they call in psychology working through. You need to work again and again and again in order to get bad habits away. So every time you feel the need or the impulse to do something, you need to counter it by a certain exercise that you've learned how to do. Like, we do the stop. Um, how to deal with the fact that drugs are available and how not to use it the same way that if people go to AA and they get a sponsor and they feel the urge, they feel the cravings, they contact the sponsor, and using some exercises that actually are very much, um, you know, come from the cognitive behavioral therapy school, all kind of exercises to prevent yourself from doing it because urges to use, urges to commit suicide, urges to eat something that is not good for your diet are waxing and waning. So the question is how to be able to, or like almost like hold your breath underwater for a while.
Wait for it to pass.
Exit and wait for it to pass and then get used to your cycle, how it works for you. And that's definitely a good step for recovery. So the first thing is motivation, and the second one is the coping skills. So that's the essence of it, basically. And I'm not telling anything people don't know, but this is what we need to emphasize to them again and again and again.
For folks that are, tuning in and maybe caught the first episode where we talked about your hopes and, what you were expecting from this, and now they're checking in, and here we are. We were talking earlier, with 2 years has gone by, but it's all said and done. What are you most proud of when you look back on the study as a whole? What is like the piece of information that came out that you think is really the piece that you're most proud of when you look back at this 2-year journey?
Okay, I don't use the term proud personally. I will call it fulfillment, professional fulfillment.
Yeah.
Because proud is, yeah, gee, I'm proud of myself. It's the fulfillment. The findings are very alarming, but it's important to know them in order to be very well prepared for some future studies that will help us kind of decipher the problem and provide people with more specific direct care to those specific issues. Because people are complex and there are multiple variables involved. I mean, it would be nice if causality would be A causes B, but a lot of time A causes B through C, D, E, all kind of mediators. There's also the term we call moderators. It depends what you are. What's your age? What's your gender? What's your ethnic, racial background? What environment you live in? What's your socioeconomic status? What's your familial status? And on and on and on and on. How do you use it in a way that will be optimal for a client that, by the way, doesn't want to stop using drugs? Because remember, there is a certain aspect of a willful activity when you take the drugs. And I'm not going to discussion different story. Is it a matter of willpower? Is it stigma to talk about it like this and so forth? But uh, you need to take the drug. You need to gamble. You need to go on the internet, in order to get addicted to something. It involves action, and in like in gambling and internet, and in drugs, it depends also on taking a drug, something concrete. So it's kind of important to understand all these ramifications, and as I said, to break it into subgroups. Now, the specific study, I would say the ratio of those who agreed to participate was probably 2 out of every 3. So that's a problem. And we tried very hard. It means that out of every 3 people we approached, 1 did not want to participate, even though we provided them with rewards. So you might ask yourself, well, um, are the results representative of everybody or mostly everybody? Because I always tend to think that those who elope from school are probably not the best students. And those who don't want to be part of it, maybe the situation or the condition is even worse. So I need to handle it with care and said what we found is pretty alarming, but it could be even much worse if we were able to get everybody, like from A to Z, and not be to some degree selective. I mean, we try not to be selective. We try to address issues from a methodological perspective of everybody who was already in the system and new admissions. But I must say that 2 out of 3 is, it's not bad, but it's not enough, because you always worry about those who are not involved. What is the
What's the
story
reason
about it.
that's holding them back?
Right, right.
What do you think we do with that? Maybe what I mean, what is there to do with that? Because I mean, obviously, free will plays into it. You know, we can't force people to do this. So what? How do we make up for that difference or that lack of information that we have from those people who maybe either because they're shy or, like you said, it just things could be going so badly in their life that they're not. It's too daunting for them.
I think it's a matter of reward. We may have to even offer them more because, we pay people for doing this. And by the way, we pay them kind of nicely. But there's an issue that has to do like with motivation. For example, people say that when people use weed, cannabis, marijuana, they manifest amotivational syndrome. People become like not interested in anything, like leave me alone, I don't want to do anything. I just want to
Relax.
space out or whatever. So the issue is the motivation, and in studies, because these people are, citizens and they are adults, they can say no, but I can ask them like, what's your price? Um, um, that could be helpful. What also helpful, in my opinion, maybe I don't know, going to do it. Well, it's just my idea. I don't know if people buy it or not. Let's say in the Root Foundation, like say if somebody like me comes and give a lecture to the patients, and you bring them coffee and donuts and whatever, so they will come and then they're going to ask some questions, and maybe they'll become curious, and I'm going to do something. I would call it a positive manipulation.
Mm-hmm.
I'm not trapping people. Say, again, talk about altruism and said, your knowledge, your experience can save health and life of other people.
Mm.
So I would like you to participate because you're helpful for us. Working with adolescents, one of the questions sometimes that I ask a kid who doesn't want us to use drugs and said, do you have any younger siblings? I said, yeah, I got a brother, I got a sister. So what do you think about them using drugs? Most of the time I say, no way, I'm not going to let them. So that's altruism. Instead of saying,
Mm.
I don't care, they can do what they want. Although I do hear that as well, but it's minuscule compared to the people. Anybody, it doesn't matter how down and out they are, show some compassion.
Mm.
It might not be even compassion to people. It could be compassion for their pets or I don't know whom. But I think this is a good way to enlist, to recruit people by appealing to their will to be good, because many of those people have also very poor self-esteem.
Mm.
And I said, this is your opportunity to make the best out of this not so great situation by helping other people. So, this is just ideas that I have given my, I don't know, 35 years in the field. So I'm entitled to some conclusions.
Mm-hmm.
Yeah.
No, it's something certainly to keep in mind because, like you said, the research on younger folks is not as pervasive because we don't want to think that, when we were talking earlier with some of these numbers, we don't want to think that somebody that young would be picking up a drug or might be in the environment where that's accessible. But unfortunately, that is what's happening. So we need to be having these studies. We need to be having these conversations because it is happening. And that's what your studies are showing. Where we do have this problem.
You know, Probably one of the first patients I've ever met many, many years ago when I started my career at Brown University in Rhode Island. I saw a kid who's 13 years old using weed, 13, from a certain area close to Providence that is known to be problematic. I'm not going to name the neighborhood. And I went with him over a list of drugs and asked him about something. He said, I don't use it anymore. And I want to say, what? You're 13 and you're not using it anymore? This
Oh,
is something
wow.
you'd like to hear from an adult, not
Mm-hmm.
somebody with 13. Oh, I don't do this stuff anymore. And then made me realize, a child as a psychiatrist, how important it is to look at things from what we call developmental perspective, what we call to be developmentally informed, because most mental health professionals have been studied, trained, and worked with adults. But it's so important to start with very young people because by the time they come to people who work with adults, they have so much history behind them, and the median age of any psychiatric disorder is probably mid-teens, and the age of pathology is going down, including depression and anxiety disorders. So the sooner we intervene, the better. And in terms of drug prevention, people say, well, we do it in high school. I said, no, you need to do it in elementary school because we see kids in middle school using drugs. And once they use it, you cannot convince them not to use it. Those who are not using it yet or are not sure whether to use or not, this is what you need to do in terms of primary prevention. And the fact of the factor of this is not cool is a very important one. So there need to be a lot of peer influence about don't do this, don't do that. Otherwise, it become cool like e-cigarettes, unfortunately. Then there's a blowout of using of e-cigarettes.
Yeah, I mean, I think it
And
was like into fourth graders, like
yeah,
like
yeah,
young elementary.
right. So kids say we're not using the bad old cigarettes. Instead of nicotine to come through the door, it comes through the window. And the industry is, of course, enhancing it because this is how you make money. You need to have new, young customer to get addicted. So that's another issue, but about how the environment is not facilitating prevention because too much is going on social media and other issues. And I don't know if you just said it's interesting. Well, a little while ago, it started in France. They issued basically a recommendation, their pediatric association, that kids under the age of 2 should not be exposed to media. Now, the American Pediatric Association here adopted it. Last week, first time, I don't know how they're going to do it. In Australia, they decided that kids under 16 cannot be exposed
Yes.
to social media like TikTok and Instagram. Let's see, good luck, how this is going to work. But to some degree, people realize now in the Congress that we let all this stuff run freely in the same way that you can learn how to make explosive online. People expose you to all kind of drugs and tell you how wonderful it is. And these kids, they buy everything, because I mean, emotionally and cognitively, say, oh, and then say, am I the only guy who has not been using it? So I gotta try it. And then one thing leads to another, and we have casualties.
Yeah. Well, it's kind of like the Wild West. We were talking about that. We had a forum on loneliness
Yeah.
just last week, and we were talking a lot about, what do we do with social media and access to information, and how do you rein that in? There is so much that you're doing and so much that you're looking over, and I know you have a book, and I know there's other projects that you're involved in, so I want to make sure we give time to not only speak about obviously what you did with us and your study, but what other projects you have going on and any other important information that you think is valuable for our listeners to take away.
Yes, we involved now in another study that is actually open for recruitment and people can access us, but trying to contact me at Kaminer, it's the last name, at ucsc.edu. We're providing free of charge psychotherapeutic treatment on an outpatient basis to young people 14 to 21 who have substance use issues. It's mainly probably cannabis and alcohol. We've been doing these treatment studies for more than 30 years because I've been about 30 years at the University of Connecticut. It used to be called Health Center, now it's called UConn Health. So we welcome recruitments. I'm very interested in comorbidity, meaning co-occurring uh, mental health issues such as depression and suicide. And we've done some studies on this issue as well in collaboration with colleagues from Duke University. This ongoing study that we're just starting actually is in collaboration with Mass General, Harvard. And it's nice that people in the field are collaborating and exchanging information and um, increasing the likelihood of outcomes that would serve very well not only the patient we've treated, but patients in other places that can perhaps the, the system or other system or agencies can generalize our findings and apply them to the trenches where they have their own clients.
And what about your book also?
Well, I published a book with my colleague Ken Winters from the University of Minnesota. It's a clinical manual for use substance use, which can be found in Amazon and in other outlets. And it's a very comprehensive book with 26 chapters written by experts in each one of those domains. The book has been adopted by several agencies and training organizations because it has been very comprehensive. Start from even pregnancy in association with substance use to depression, PTSD, self-help interventions, pretty much the entire gamut that we thought was meaningful to work with the young people, again, up to the age of 25. There's no geriatrics there, so it's just for children, adolescents, and youth.
Awesome. And we'll make sure to put this in our caption of our podcast for folks who are interested. Youth Addictive Disorders, the clinical manual. We'll have that online if folks are interested in learning more, getting a copy. I think it's really interesting as you're saying that, you're providing this insight for parents, for anybody really, to just take this information and apply it. And like you said, maybe use that altruistic inner self and try to help somebody else. So Dr. Kaminer, we thank you so much for coming on. Really pleased to hear that, the study went well and you're awaiting publication now, right?
Yes, we will present it in a conference and submit it to a peer-reviewed journal. I think it's a very interesting study, and hopefully it will be published sooner than later.
Well, of course, and then we'll share it with all of our Root fans as well. Dr. Kaminer, thank you so much for coming on. Again, it was really a pleasure to chat with you.
Thank you.
Well, we hope you enjoyed this episode of our podcast, Recovery with Root. As always, stay connected with us on social media to learn about when next podcast episodes will drop. You can comment, ask questions, even let us know about future topics that you'd like to see discussed. Until next time, remember, progress is the destination.